Hello, SAGES community. I'd like to take a moment to thank SAGES as well as the moderators for the opportunity to present to you today. I'm very excited to be invited to speak at the first ever virtual SAGES here 2020. And I'd like to talk with you today about algorithmic approaches to infected mesh salvage. Here you have the ventral hernia repair, a mesh infection, or maybe one that's referred to you. Do you need to operate, or can you find other alternatives to salvage that mesh? I have no conflicts of interest with this talk today, and I want to state that my opinions are of my own and do not represent that of the DoD or United States Navy. So here they come into your office, that dreaded hostile abdomen, the consideration of if this is a suture granuloma gone too long, or fistula that pours out purulence, that then you find that broccoli floret, what's going to come out of the wound and how is it going to be managed, whether in your office and non-operative measures, you considering that partial removal of the mesh just around a hot area, hot zone, or are we taking all that mesh out, and how are you deciding that algorithm? Who can have their mesh saved and who cannot? Herein you see that heavyweight mesh and its fixation as the bowel was able to be salvaged yet needed repair. One of those non-salvageable, but how do you get to that point to know, and what are those factors you need to consider for your patient to know the difference? So our early understanding of mesh infection and how to manage. When considering those heavier weight meshes back in 2007, earlier publications of debating, do we limit our excision versus full removal? Does it depend on a limited per se infection versus a completely infected mesh? And attempts at full removal versus can we get by with drainage and antibiotics? And you'll see here from Dr. Henneford's group, as well as when Dr. Rosen published in 2009, and his consideration of not only the mesh factors, as Dr. Henneford had published, but also patient factors, the MRSA history in a patient. Even when you can salvage the mesh, they're on suppressive lifelong antibiotics, and that was a consideration of what's better or best practices for the patient and their repair. So what's new in 2020? Certainly there's been a lot of gradation between that time frame, but we've heard time again as we have these annual conferences of what people are doing, what have we been doing in the last year with these mesh infections, and who can we salvage? So let's talk about biologic meshes. What's the latest on those publications in those contaminated fields? So you can see just published in April of 2020 from Dr. Yeakel's group, Stratus mesh, 27 patients, and a 42-month follow-up in these contaminated fields. None of these cases required mesh removal, and 26% though did result in a recurrence of the hernia itself and thereby needing to be managed. So there is some risk benefit on biologic meshes, as we've historically known and continue to see even in this year. How about in May of 2020, recent publication on phasics, so similar prosthetic concept. Median follow-up at 3 years and 105 patients. Now it's important to note in this particular study, only 30% were in contaminated cases of the 105 patients, yet only less than 3% required a reoperation, meaning mesh excision included in that, yet with a compromise of 17% recurrence rate. So definitely that give and take, independent of what biologic mesh you're using. And the similarly found even in Tigrix mesh, of which Dr. Ramshaw published just this May of 2020 in 91 patients. Only 30% again of those patients were active infections, but no mesh was required to be removed, however, at a compromise of a 12% recurrence rate. So then what about the consideration of synthetic meshes? Certainly people have said, well, I don't want to spend the cost of biologic meshes. Let's use synthetic meshes. What are the outcomes of that? Contaminated fields. So in April 2020 in JACS, Dr. Carbonell and Dr. Cobb had published considering 542 contaminated cases at their single institution and collaborating between their own internal database and AHSQC. Their follow-up median average was 2.5 years. They used 402 of those cases as permanent meshes, and they had identified a 14% surgical site infection rate. Now, 10.5% of that was recurrence rate. So it's less, certainly less than what we'd seen in the biologics, and only a 1% requirement of mesh removal for those. So why would we even consider to salvage mesh? Why not just remove them all, get it done with, move on? Is there a cost of removing these meshes, removing that infection? So Dr. Roth's group just published this year a retrospective review at their institution, 34 patients, average time to infection from hernia repair to the declaration of their mesh infection at 19.5 months. And the median hospital cost was 2 times that of the initial ventral hernia repair for the mesh removal admission. So it's very costly to just take mesh out. And if there's times we can salvage, we need to know what patients are the right ones to attempt this on. What intraoperative techniques may we consider? So porosity of the mesh, is there a difference there that then makes it salvageable? Just this year, Dr. Hensman's group published on consideration of the porosity of the mesh and its biofilm. This is published in Hernia. I think it's a great paper, one that I'm going to look back on and continue to reference. So when considering macroporous, or that greater than 1,000 nanometers pore size, it results in less hostile inflammatory reaction, which means less fibrosis or scar plate, and thus better mesh integration. So that's what you want. You want great mesh integration with the native tissue so that it has better blood supply to that area, thus meaning antibiotics can get in better into that field, and there's just more tissue sandwiched around that scaffolding. Now, beyond the pore size or factors that can overcome even a macroporish mesh size that were affecting the ability to have that better mesh integration. If there was a bend or fold in the mesh, if you're laying the mesh down and you have that bend or fold, that's going to increase that risk of that scar plate to form. Also overstretching. So you think, okay, well, I want it to be nice and tight out. There'll be no wrinkles in my mesh. The intent of when you outstretch that mesh too far, it changes the construct of the pore and affects the axial load of the mesh itself. So you don't want to overstretch the mesh either. As well, even if you have large pore size, but you have a barrier, and it's not necessarily, okay, we had something that was high risk, like a secure mesh barrier, or the some of the antibiotic coated meshes that may have an effect to increasing those risks of infections. But really any barrier actually affects the mesh integration. And when it affects mesh integration, it's going to affect the ability to salvage that mesh should it get infected. Also, same effects have been seen, as they mentioned here in the paper, for hybrid meshes, those bioprosthetics. All of these factors could then result in a biofilm to form, which is then less effective to clear the potential infection. So if you missed that, is there any preventative work we can do? As mentioned by Hausman in his paper that I just mentioned, stating, well, if we had better techniques, we could minimize the risk of bacterial contamination in the first place. Thus, these factors are less important to even introduce bacteria in that original operation. And Dr. Janis looked at this just in May of 2020, publishing his current technique he's going to build off of, and saying, okay, I'm doing all these things, trying to do a no-touch technique of mesh to lay it in, to thereby minimize the mesh infection risk. And as you can see, even considering 90% of his cases in the paper are clean cases, still 4.5% infection rate and nearly 2.5% mesh infection rate. And that's with all the things you might consider: betadine skin prep, antibiotic incision irrigation, triple antibiotic irrigation, which he does twice in his methodology as stated here, replacing instruments, new gloves, mesh dip and antibiotic, directly into the wound. It bypasses the Mayo stand, bypasses the drapes, all that. So even with that, we're never going to get in that 0% mesh infection or complication risk. So what if you take out just part of the mesh? Will that get you by? Can you do a partial mesh excision? Well, a meta-analysis just published this year on that considered, well, what's the risk of recurrent infection? If we're saying, okay, partial removal, now I've cleared the infection, we'll start the clock at 0. Well, 58% of the time that was resulting in a recurrent infection. And the real question is, was there a smoldering underlying infection that then brought itself back to light and was never really resolved in the first place, versus complete removal of the mesh, and that was only a quarter of the time that they had a recurrent infection. So certainly that partial removal results in failure more often than not, and complete removal should be considered so that these patients can then move on to that definitive repair at a more timely fashion. So there are any adjuncts you need to consider at the time of treating a mesh infection to really make sure you're clearing it appropriately. A recent publication in January just discussing sonication of the mesh sample to be able to really gain the highest yield of growth of bacteria that may be on the mesh. So are you taking those cotton swabs and swiping the mesh? Is that going to be enough to show you what bacteria is there? And here it's suggested that you actually take a sample of the mesh, the exact processes on how to do the culture appropriately, and then the commonality of them more often than not showing a positive culture. Within this study, the number one mesh infection bacteria was Staph aureus, specifically MRSA, and number two was Candida. So it's consistent with what's seen in other literature as they'd seen in this study, but yet a higher yield of positive cultures if considering this technique. So let's talk about salvage. So what can we do to say, okay, you're a patient that's worth trying salvage. It's possible for us to salvage your mesh without having to remove it, compared to those who say, you know what, we need to move straight to removal. It's going to be long visits in the hospital, or certainly at least in the clinic for wound care. How do you delineate amongst those patients? So Dr. Carbonell just recently published his 213 cases just this year retrospective review, consistent with what Dr. Roth was seeing in a 19-month time to presentation. And factors that promoted the ability to salvage the mesh included a macroporous polypropylene. We've discussed this before. We know that porosity is a factor. Do remember that those lightest weight meshes can result in central fracturing, and certainly in the face of infection has a more likelihood to occur. Now that's only affecting recurrence, but it just needs to be considered. So that mid-weight polypropylene can be a consideration at that initial ventral hernia in the uncontaminated field, and then known that if they get infected, they still have more of a likelihood of clearing the infection. Extraperitoneal position cannot be overemphasized, not only in this study, but I'll show you next Dr. Augenstein's study on mesh infections as well. And those intraperitoneal meshes or IPOM techniques, those are the ones that had the highest likelihood to have a mesh infection that was unsalvageable. No subsequent operations. So Dr. Carbonell was able to identify that if there was an interval procedure between the time of their initial ventral hernia repair, they're clearing a mesh infection, but then they had a mid-operation, then they weren't able to clear that infection similarly, and it was no longer able to be salvaged. Patient factors. So if they're not a diabetic, they're more likely to be able to salvage. He also looked at the ability of extrapolating similar concepts of patient factors such as smokers or other comorbidities, but there was no statistical significance behind these. Their salvage treatments were negative pressure wound therapy and local wound care, as well as antibiotics. As mentioned, Dr. Augenstein and Dr. Henneford's group also looked at mesh infection and salvageability of meshage, and over 200 patients within their study, demonstrating that the median time was about 90 days, yet a third of the patients were over a year of time to presentation. You know, having worked directly within this database, I could tell you it was commonly, surgeons would think, oh, it's a suture granuloma, oh, it's just a stitch pitting out. They would wash that wound form, and then slowly over time would scan and then identify. 70% of this database collection were referred in mesh infections, and time again, reviewing through the notes, it was a slow roll to call the infection. So what are the salvageable factors of the patients as a whole in the group? We identified non-smokers were more likely to be able to clear infection. Vice the smokers, they could not clear. They cannot smoke and get their mesh salvaged. And in fact, there needs to be consideration on, even when they are smokers, should they just be on chronic suppressive antibiotics if you can get them to that stage, versus taking out their mesh and expecting a miracle. You also have the lightweight polypropylene, again, seen here as we might be considering that mid-weight, as that was the common practice for this group of what weight of polypropylene mesh was used in ventral hernias. Non-barrier mesh was a positive predictor for salvageable mesh in not having to have it explanted. But with the barrier meshes, they were not able to clear as easily. And then absence of mesh fistula. If they have a fistula, it has to be removed. There was no way around clearing that infection. MRSA infections were more likely to need removal, meaning if it was a non-MRSA, it was worth trying to salvage in consideration of these other factors as mentioned. So salvage treatment, again, negative pressure wound therapy, local wound care, and in some cases, chronic long-term suppressive antibiotics. But it does then put it into the patient's choice. So in conclusion, when you're considering, is the mesh, can you save the mesh? Is it salvageable? Fistula present? Yes, you got to excise. If it's not present, then you consider things as if the patient is a smoker. Yes, you're going to have to excise. As I mentioned, the other consideration is chronic suppressive antibiotics if they're able to get to that stage. If they're not a smoker, then you're looking at types of mesh. So polypropylene versus PTFE. And if you have that weighted type of polypropylene, that heavy weight, 0% were salvageable. So it's heavier weight message or dual message, you're having to excise. But if it's lightweight or lighter weight, like the mid-weight, and there's MRSA present, then again, you're looking at excision compared to when it's not MRSA, they may be able to salvage. Do have to counsel the patient. That means 24 weeks median of antibiotic therapy, and a quarter of the patients requiring chronic lifelong suppressive antibiotics. So I just want to thank you for the opportunity to present to you today the latest on salvageable mesh infections and when you know you can give the patient a chance versus when you know you have to do an operation. Enjoy Virtual SAGES 2020, and I look forward to seeing you in the years to come.